Welcome to this fourth module of our CardioNext program. I think multivessel PCI is another area where all of us should become more and more aware because significant patients of our procedures in cath lab are involved with multivessel. Not we will also take you through how this is important. And if you see, this has been my area of interest too. In passionate about this since long. We have been doing live cases and also taking care of complex patients. Nowadays, I think 20% of our referrals come from surgical colleagues requesting to help these patients who are high risk for surgery or not suitable for surgery. And sometimes patients do come with CDs to help them with avoiding surgery. But what we need to have is a complete revascularization and do a good job to these patients. Let us here, I'll tell you in more detail about subsequent all these slides and then take you through. Brings best wishes from Apollo Group of Hospitals. I'm proud to present my fax professionals colleagues. It's very important to have a hub and very good colleagues because yesterday we did some very complicated cases like two left mains and other multivessel PCIs. And again, even if I'm busy here, I'm very confident that my colleagues would have taken care of the patient and the same way as me. That's very important. That's how we help each other at work and on the other hospitals too. We do get some referrals for such complicated cases wherever you multivessel PCI or multiple stents involved, the image guidance is involved. Probably each of our colleagues could help with cases coming from those to Apollo Hospital. With that brief intro, what I would like to mention is basically tell you the incidents of. Hope I'm audible and clear. Vignesh, hope I'm audible and clear for everybody. Can we make it shorter so that I see the chat on the right side? Is there any way to do that? I'll try to do that. Can you ask others to mute their mics, please?
Yes, sir. We'll mute it from our side, sir.
Yeah. Okay. I think we can have some time in the end to discuss in the questions in the chat. I wanted to make it more interactive and live. If the chat box comes on the right side of the screen to me, I'm not able to get it like that. I don't know how to do it. Then anyway, what we would like to do is we will take you through the evolution of a multivessel PCI, what it was when the PCI was started and to what it is now in 2020. And it's very important for all of you to understand the second step, the decision-making process of multivessel PCI and how to do it. And if your patient has 3 vessels, then which one to tackle first and what is thing, how we decide on that, I will go through that. And the scientific basis, are we doing right? We need to have strong basis to explain to patients, not only to explain to patients to satisfy ourselves and do what is right to the patients. We need to have an idea about this and quote if somebody is asking about the importance of it. And take you through some case examples. Case examples depicting some of the important aspects like other new modality which is comparable to FFR, which is come is the QFR, which is a non-invasive way of assessing FFR. This fortunately, because of our relation with Netherlands Medis, we could have it, and it's about to be launched in the country. We did some live cases before that, and I'll show you that. And we are now dealing with 90-year-old patient, triple vessel with history of stroke, and when it is there, then how to tackle it, that will show in the multivessel PCI. Second case example. Another case example is again octogenarian. Our patient start resembling West, and he has a CKD, dialysis, and very calcific disease. This is where I will also touch upon the management of calcific multivessel disease with the help of ROTA, and then also using some of this additional stuff like guide extension, things like that. And then also sometimes we come across this multivessel PCI in acute coronary syndrome type of setups and STEMI. In that case, how do you decide? And what is the importance of FFR? I'll touch upon some of the important principles of FFR, how the FFR varies when depending upon the area of supply, and then depending upon the collateral formation, how it happens. Then I think if time permits, I would also show a live in a box case I promise to all of you that if there is no time for taking chat questions or having interactions today, I would definitely cover up what are the doubts we have in multiversal PCI in the next module and conclude. This will be the agenda for coming about 45 to 50 minutes. Now, if you see, PCI was just started for single vessel disease before. And then all this diffuse left main disease, multivessel disease, complex left main, all that was a part of surgery. So now, as the PCI evolves with better quality techniques coming, PCI encompassed of everything. Now we have not only multivessel disease, but left main, everything is taken care, is taken, will be, are being done by multivessel PCI. If you see the evolution in the early 90s, then this was it. So single vessel disease only was done by PCI. Multivessel disease, 82% were done by surgery. Whereas here, now 80% of multivessel disease is being taken care by PCI. This is latest 2020 data. Very fortunate to collect our country's data. How much is that when I was chairman for NIC? And that year, out of a 4,38,351 PCI is done, so multivessel disease contributed 25%. Rightly so, probably 1/4 of the patients are of multivessel disease. That's why it's important for us to understand this technology well and also become comfortable with these various things which got involved in the multivessel PCI like IVOS, FFR, and usage of rotablation calcific disease, because you need to take the help of these devices to do the procedures right. With that intro, I would like to take you through the decision-making process of multivessel disease. People have the habit of writing TVD and send the patients to surgery or the other way, but you need to understand that we need to understand that it is not the question of only semantics to write a single vessel, double vessel, or triple vessel. Basically, it depends upon each vessel. Where is the lesion? Where the lesion is the proximal, as you understand, becomes more important. If it is mid or distal, it becomes less important. Suppose LAD has a very distal lesion at the apex, you don't consider it as like proximal LAD involvement. That is because, as we all know, how much area is supplied by the LAD becomes important. Similarly, lesion significance, if it has to be critical, moderate, mild, or total occlusion becomes important. Some of the people in the periphery, generally we keep seeing it that patients write about 50, doctors do write about 50% lesion, and when we do FFR, things like that, it becomes hardly important. So many of these patients of so-called triple vessel disease could become have only significant disease one vessel and insignificant the other vessels. So when we are doing, when we are thinking as triple vessel disease, what we mean is there should be lesion should be in the proximal location, and also all of them should be of important significance. I think all of you are aware by this now that what is important lesion and FFR, how much it becomes important. All that, if we had chat, we could have discussed. Now going, I will see. So other important thing what is important in decision making process is LV function. If a patient has normal LV function, it has different connotation. If patient has LV dysfunction, it has different connotation. That means if a patient has LV dysfunction, that means we have data now that more complete revasculation is required. People think that LV dysfunction is always equivalent to surgery. It's not so. LV dysfunction, what it needs is needs total revasculation. That means every segment of the myocardium contributes to pumping function of the heart. So that's how LV function, LV dysfunction presence needs more complete revasculation. If you can offer that by percutaneous therapy, it is fine. But generally, people think that, and also it's true that patient who has associated LV dysfunction could benefit more by surgical therapy because each and every vessel could be revascularized. But the same thing, if you are able to do percutaneously, it's also good. And we have seen patients of severe LV dysfunction after percutaneous revascularization also becoming totally normal and having a normal lifespan later in life. So it is not that LV function improves only with surgery, but any effective revascularization, LV function improves. And the symptom status and clinical scenario is finally the most important parameter by which we decide what needs to be done. If a patient presents with acute MI and acute coronary syndrome with dynamic ECG changes, hemodynamic instability, it is not easy for a surgeon also to tackle it immediately. By the time surgery is arranged, and then probably if he infarcts further and LV dysfunction sets in, the idea is the important aspect of it, taking care of myocardium will be lost. And then suppose patient is not in a position to get a surgical done immediately in a setup where surgery is not appropriate, that also goes a long way. So that means to say that the experience and the things of the center, which is in which the patient presents, also become important. I wish and I want to present to all the junior colleagues that cardiologists in periphery think that it is okay to send the patient for surgery, and they feel bad about sending a patient for revasculation to another senior cardiology colleague in a better hospital, which has a better handling capacity. There's nothing to feel very ill about it. It is basically the setup is important. Suppose you need IVAS, rotablation, and things like that. If all the cases which I've sent, I'm very happy. Some of the junior colleagues who have sent from there, patients are referred from Karimnagar and things like that for these procedures, and where we could do patients and when the patients come and follow up with no symptoms and LV function improvement, we feel a lot good about it. So that is the importance of a decision-making process. It just don't go by single vessel, double vessel, or triple vessel. That's why you practice habit of writing the final report also as describing the lesion rather than just writing as multivessel, double vessel, triple vessel. You can write CAD, proximal LAD disease pattern, or middle AD LCX and distal RCA, something like that, because it has its own connotations and importance. So though starting you can might label it as triple vessel disease, but it has to be noted what is important, how important is the vessel disease in each of it. Then why now we know that complete revasculation is important. What is complete revasculation? Whether it is complete anatomical revasculation, where every small branch, even of 1.5 millimeters, should be revascularized. Maybe not, because even the surgery also the graft. There some vessels will be non-graftable, and some vessels which are very thin are also non-stentable. But nowadays, if a vessel is very thin and long, we do get smaller vessels, and we do have regulating balloons to take up some of these patients. If it is physiologically very important, some of these vessels which are thin but supply a large area of myocardium again becomes important. So when we are planning, contemplating the opening of the vessel, we should always see the risk benefit ratio of opening that vessel versus something happens. And then situation in the acute MI stage, probably you tend to do culprit vessel and then plan other vessels later. So if you have to define revasculation, it's not anatomical revasculation. We don't want to open up every smaller vessel, but we want a functionally complete revasculation. That's how syntax 2 score also has come, taking the importance of a functional importance of each of this vessel. PCI of every occluded vessel, it is not that every stenotic vessel, but vessels which are supplying a reasonable amount of myocardium needs to be revascularized. And when do you plan only culprit vessel? As I said, culprit vessel revasculation is planned in the setups of acute ischemia, acute MI, and then probably the staged way other vessels could be done. So if it's not dealing with this, then some doctors, it's not to be quoted, not to be told, some of good, bad is there everywhere. But sometimes some smaller vessel, which is just stentable, if you stent it, leaving a CTO or some difficult vessel, then that is no good to this patient. So it is not to be done, encouraged at all. So we need to have a plan, functionally complete revasculation. Now that we know how you have to express this and what is we have to do a functionally complete revasculation. Now we'll go further into details of these lesions, what type of it and how we have to manage this, and we will see through that. If you have a triple vessel disease like this, you have a LCX OM tight stenosis, you have a diagonal and artery disease here, and if you have RCA, it's a very proximal disease. One thing I want to tell you, if none of the vessel is occluded, all the vessels have lesions, syntax won't come important at all. So you need not worry about high syntax patient not being planned for surgery. So here, LAD diagonal is tackled again in a positive way. If at all, if you have to use kissing balloon, it's also done. And then RCA is also tackled, OM is tackled. Nowadays, putting the smaller size stents is no big deal. And we will be able to do a good job, especially the availability of drug-eluting stents. Now, that's how various contemporary trials, I said I would also review in between what is the literature shows. Basically, if you see the contemporary trials, how it has come, the various ARTS 1 trial, it was compared CABG versus PCI in a bare metal stents. ARTS 2 trial has compared PCI, multivessel PCI with CABG in drug-eluting stent era. And that's where we started having more data of syntax, freedom, best, and some of the registries also. It is always said that if a patient has diabetes, then surgery is course over. That's how it came in freedom trial. But it again, we need to see it is if it is the patient has diabetes, it's not that it's absolutely not no to PCI. But if you have to do a good job with a better quality stents, and then probably if you achieve the results immediately well, then probably even in diabetes patients, you could actually do appropriate therapy. Some of this we will review in some of these things. So now that we have so much data, we can do it safely. That becomes most important. If you plan to do a procedure and your patient lands in trouble in between, then that is a problem. Then you 1 minute. Then we need to do the procedure safely. So multiple trials showed that if a patient you can revascularize safely, you can do it. But we should be also able to do revascularize as equally as our surgical colleagues. I think we have a lot of trials showing that if the patient has associated LV dysfunction, it could be better with surgery, not with PCI. And sometimes you could have multiple revascularizations which are required. That is the only problem with multiple PCI. If the patients of repeat procedures need to be explained. If the syntax is favorable, then can we do it for everybody? That is not easy in doing these calcifications. We need to put in efforts. And what we need to have is the key issues like complete revasculation. And then should even you're tackling with long stents, we should avoid getting into procedural MI. And calcification sometimes limits the stent expansion. These are what is more important. The length of the stents was more important in the bare metal era, but now with with the availability of drug-eluting stents away from the cipher eras, the serious trial which was done, the length was no more important. But generally now it is said for the idea for you people, if you have to, if the stent lengths are crossing maybe 6 centimeters, that's 60 mm, that's where I think you need to be a little more careful. And as long as you're less than that, then drug-eluting stents are reasonably fine. Then procedural MI is one. If you get it, then the chance of patients getting into trouble will increase. So you need to take this and again prevent the occurrence of even the minor elevations of enzymes while doing this procedure. That means you need to take care of the branch vessels if at all you are doing the procedure. Incomplete stent expansion. That's where I think a lot of new technology is coming. All of us are again concentrating and doing our best to avoid these incomplete stent expansions in the calcific lesions by appropriate bed preparation, because incomplete stent expansion leads to major cause of not only late stenosis but immediate stent thrombosis. At the same time, our surgical colleagues also don't sit quiet. It is actually quite healthy a competition both with surgery and the cardiology, and they also start doing multiple new things. They started doing arterial conduit, total arterial revasculation, op cap, mid cap, very small incisions. Dr. Gokhale in our hospital and many others do these very small minimal incisions. Also take the help of robotic conduits and the cell savers, and all these are there, good. But if it is all are good, then probably the only thing which surgeons suffer is if you don't do the grafting under vision, then probably significant number of grafts could get occluded. If in this prevent 4 trial, vein graft failure again is about 40%. So this is they try to use the various other new transcription factors and how to new techniques of vein harvesting. But still, the venous grafts are not as good as drug-eluting stents. And then stent thrombosis, if at all we have, it's less than 1%. But vein grafts occlusions is significant. But the strength of surgery is lima, because limas function quite well. Before I go on to the individual case examples, I'll briefly take you through this approach pathway of multivessel revasculation, which I already dealt, but I'll tell you as a flow chart. When you people come across with a patient with multivessel disease, then what you calculate now, all of you must be comparable with syntax score, and you have it available also readily. You can calculate in smartphones, and then you also think about Euroscore, that is very procedural risk score, and that should be calculated. Then PCI, now if you're planning with a drug-eluting stent or surgery, these are the two options which we have in front of us. And if a patient is acute MI, ACS scenario, then please, it's not easy to plan surgery straight away in those acute MI within 6 hours, ACS or acute MI without losing the important time, or for that matter, patient post-MI or acute coronary syndrome. This is a stance of higher risk. And then you plan, if it is the acute stage, first 6 hours or so, the PCI of culprit vessel is done. then later and evaluate other lesions and do a staged procedure. Now the data is coming up even in this phase that using of a FFR could be beneficial, but FFR is there more for the stable coronary artery disease, because in these acute stages, the thrombosis and the spasm could lead to false positive results of FFR. That's how people stabilize the culprit vessel and plan the other vessels in a staged manner before discharge. That's where the consensus is going. And when you're planning in a stable patient, if you're having one vessel of like a CTO, other vessels are easily doable. You need to tackle the complex vessel first, and that is why so, because if you can't open up the CTO and open up a small branch which has a lesion, then the other important vessel, then which could have been benefit with surgery, then you will fail to do so. So first you should do the complex vessel, the most difficult vessel, or the vessel which supplies the larger area, which if everything is same, probably LAD will be given importance maximum to be tackled first, unless the lesion is in the other vessels are very critical, and that is a culprit vessel. Generally, by and large, we tend to give importance to LAD because LAD supplies some maximum amount of area. Then, depending upon other important scenario, what we need to keep in mind is the renal status. If the kidney function, creatinine is all right, you could do all the lesions in one setting. If the creatinine is on the higher side, probably you need to stage this procedure. But the final aim is doing a complete revascularization, either in the same stage or in a staged procedure. The idea should be for complete revascularization. If one of the CTOs you cannot do it properly, then that is not complete revascularization. You do injustice to the patient. So that's how we are not supposed to take care of those patients in that way. And then if the patient is not high risk for surgery, and then if one of it is a CTO, in the today's era, when do you patient send for surgery, they keep asking. One of it is if a patient has a complicated left main bifurcation, and then probably if a patient is not willing for repeat procedures, or if a patient has two CTO occlusions, two total occlusions involving LAD proximal, those are the patients probably in today's era also benefit by surgery, which would be less than 20%. And the rest, all about 80% of the cases of multivessel could be tackled by surgery. Hope I made this clear, and we can have some discussion in the chat later about this. So this is a very important flowchart. All of you can have it in mind. Then we go on to the case examples. We have been passionate about this. We did live transmission way back in 2020 to TCT USA, again with multivessel. Those are the times of first, second generation stents of Promus and other things which were shown. Then multivessel PCI, and we could tackle all the three vessels in the allotted 50 minutes time, and which was given. And recently, I think after coming to Apollo, we did multivessel PCI. We wanted to highlight this effect of QFR. If you see the still pictures, I will go take you through the other details of this patient. Patient was 16-year-old male. I'm extremely thankful to all my colleagues which are seen in this. Though I do it, a lot of help, support is done by all my colleagues. I'm extremely thankful and happy to have such extremely good colleagues like Dr. Gokul, Sanjeev, Ramakrishna. All of us work with each other and try to do what is good for the patients. It's also important in doing the procedure, which I will be touching upon how to have a good colleagues with it doing this case. I think you are able to see this moving. This patient has a multivessel disease. He has a left circumflex artery. Here we thought it is borderline. And then probably you have a LAD, which is mid LAD anyways, was thought to be critical. And then in multiple different views also we took. And then this is the LAD system. Now you see that's the importance of having views also. LAD didn't look much there, but I think here everybody agreed that this LAD is critical here. So in the other vessels, then LAD was easily tackled. It's not a proximal LAD, mid LAD. Then that was immediately done within first 10 minutes or so. Then we didn't want to highlight that aspect, but we wanted to highlight this of lesion assessment in the left circumflex artery and the OM. And then these are the mechanism of QFR. I think some of you who worked with us and had exposure to this, you must be knowing it. QFR is another new technology to calculate effective fractional flow disorder like that, which is called as QFR, by taking two angulated views of 25 degrees apart. And you have you see it here, a LO view and RA view. And you take the marks and the computer calculates it within no time. And the beauty of it is if you scroll the lesion point here, you get a particular FFR value at that particular segment. So if you have a multiple levels of disease, again, it shows very clearly. If you keep moving it, you get a value at that particular place, and then you can do effective therapy to this patient. So this LCX FFR came, which is calculated as QFR showed as 0.85 and FFR showed 0.82. And then that's how we calculated it. This is the FFR wire. Other thing, what you need to see is also see the drift while withdrawing. This was there with a FFR wire, which is not required with QFR, because QFR, the movement of that scrolling the bar will tell you at which point it is becoming important. This is right coronary artery. Right coronary artery is again has a disease which I thought may not be important. Sanjeev Kumar, my colleague, got this patient from Mahbub Nagar. Actually, he felt this lesion could be because of this, and then we were contemplating whether to do this or not. That's where we started calculating, and to show it as it is effectively, if you're doing a QFR with adenosine, suddenly patients could develop into bradycardia and develop trouble. That's what has happened. With adenosine, patient developed bradycardia, then QFR came as 0.80. So FFR also came important. That's how we stented this. That is not a point of interest to show it. 0.78, the stenting and the post-dilatation all was done. And finally, we had a good result. For the sake of time, I'm skipping through. So this was effectively appreciated and all the panelists there in TCT also appreciated. And we are able to do all this procedure in allotted 50 minutes of time. That's the beauty of technology and having good teamwork and having all the facilities together. So that's how we could show that QFR is another modality of importance in place of FFR, which can be used for tackling multivessel PCI. Another case example, I would take you to Nanogerarian, 92 years, frail personality with CVA, but he was getting recurrent rest angina and calcified triple vessel disease. He went for surgeon. Surgeon said, please take care of this patient because he also has very frail body and old CVA. See these vessels. All the vessels are calcified. He has a significant LCX disease here. Then probably LAD, you show it better in this cranial view. We had LAD diagonals there. Then he also had a disease in the right coronary artery. So we thought of tackling these vessels, and then because of frailty and TIA, for the sake of time, I didn't go into it. Distal LAD was tackled. Fortunately, nothing happened to the branch because of white cell, the open cell design, so the diagonal was okay. Then this LCX, which was there, again, if you show it, I skipped the stages of procedure, nothing much in it. Again, after stenting, this patient had improved significantly. After this patient had elevated blood pressures, had some small TIA-like issues again, but fortunately, patient did fine and we discharged. Another patient is right coronary artery was staged later. Then another 81-year-old male active patient, CKD, again, during dialysis, he was getting recurrent episodes of pain and ST depressions. And if you see the vessels again, calcific vessels, LCX has a very proximal tight stenosis. LAD, we thought is borderline. This patient, LAD, we thought we could leave. The culprit vessel, the patient was getting pain with inferior lateral changes. That's how we thought LCX and RCA should be tackled. And when we tried to attempt that, initially we could pass a balloon, smaller balloons, but bigger balloons were not going. This is the extension of guide. Many of you must have seen that is guideliner or Godzilla, what you call. And then we attempted with that, still it couldn't go. That's where we decided to do rotablate this vessel, and that is a rotablation burr, and remove tackle that calcific lesion effectively. Then once the rotablation is done, though rotablation may not open up the vessel totally, you might need to take the help of, again, NC balloons to expand it further, but that allows NC balloons to go. And the stent was, again, when being deployed with the help of a guideliner, if you see there. And then we had a NC balloon. Post-dilatation also needs to be done to prepare the patient well. And that's how the final result we could achieve in this calcific LCX disease. Then this is another lesion of the same patient, a right coronary artery. We had to use 2 wires and the Grand Slam wire for better support. And I'm not going to all this. Again, we initially tried to with the balloons, we couldn't do it. Again, we had to take the help of rotablation. And generally, we have to also be careful by using TPI or doing rotablation, especially for right coronary artery. Fortunately, it's not required here. And the multiple smaller stents, it's better to take rather than a longer stent in such calcified lesions because you tend to get into trouble with longer stents. And this is why the RCA was also revascularized and patient did fine. And he was all right until the last follow-up, I think after 2 years later, and he had succumbed because of some other problems. This is another patient. This is important to demonstrate what is acute coronary syndrome and how to tackle such patient. This patient is a 64-year-old male, history of hypertension, diabetes, and arthritis. I think presented with left-sided chest pain. He was referred from I think Karim Nagar, my colleague there, and had sweating, chest pain, breathlessness is 1 week, and then thought to be NSTEMI and severe dysfunction. But he fortunately was slightly stabilized and referred here for further management. See this. This is a patient who had subtotal occlusion of left circumflex artery, which is filling slowly. You see this. This is very important for us to assess whether there's any faint antegrade track or whether it is CTO. Here, of course, we also have a history which is only one to 2 weeks old. Sometimes you may not have a very clear-cut history. You need to assess whether you'll be able to revascularize it right or not. That is the way angiogram analysis becomes important. That's what we dealt in the principles of angiography in the first session. You see the LAD again. You have a proximal lesion here, another lesion here, 2 levels of stenosis in LAD, which are looking borderline. Then right coronary artery obviously has another critical stenosis of total occlusion. So you could have think culprit being right or left circumflex. That's how well planning important. And then we thought LAD, if FFR is done for LAD, if it becomes not important, then it could be PCI. But if FFR comes important, probably you could rediscuss with patient surgery, which we did. But even if it comes important, he was not willing for the surgery. So that's how we had to persuade and did a multivessel PCI in this patient. So this is a FFR wire. We passed the FFR and then calculated FFR in this patient. Also seen the drift. This is how you need to check, because nowadays you have RFR and you have QFR to assess which level it is important. But previously we were doing like this to assess the lesion. FFR to proximal LAD pre-adenosine came 0.88, post-adenosine became significant, and patient started having angina. That's how we are forced to tackle this first. But otherwise, generally the critical most lesion has to be tackled first. And then post-stent proximal LAD lesion again was 0.85, and post-adenosine just became less than 0.8. So I was thinking whether what is this cause, because we didn't find anatomically the second lesion important, but that's how it was giving collaterals to RCA. Once we thought we would recheck LAD FFR after revasculation of RCA, which I'll take you through the steps to see. LAD, the proximal stent is being done. That's not a problem. We had a good result. If you see this is what I was talking of. So this proximal is taken care, but the second vessel here didn't look important. But when we did FFR, it came just like 0.78, and then we thought we would do this should have been done first, but because of a patient became symptomatic and we did it. It's not the right thing to do. The LCX again we tackled, fortunately, because we're confident of track. Fielder XT wire we could track, and we did a dilatation with the balloon, and then now with the better quality stents available, now we could stent this vessel well, and you had a good result. So that's how the LCX stenting was done. Then this entire thing was quite well. Then right coronary artery, this is what it was seen, the tortuous right coronary artery. Sometimes you need to plan your procedure well, use multiple wires to have better support when you're tackling such lesions. Fielder XT wire again crossed. Many of the times people ask, what is your favorite balloon? Generally, the Tyrimo balloons or low profile balloons are good initially to tackle. And we did use those, and then we stented it. Initially, we were not sure about distal vessel, and the mid and proximal were tackled. Then he had another lesion distally. We were again, another stent was required, and that was also tackled effectively. That's how when you're tackling such patients, you shouldn't have the pressure of finances also. Then then after right coronary artery was revascularized, we did LAD PTCA again. Now it became not important that the supply area. Now we are repeating FFR here. And previously, if you watch, this LAD was giving collaterals to right coronary artery, which was occluded distally. Now that it's not there, the borderline thing became not important. That's how we left the distal vessel. So this is a concept which needs to be further studied, but it's very important for us to know that FFR values go by depends upon what is the west area of the territory which is supplying. Suppose that's the importance of FFR, unlike other testings, because it also tells you how much important is that vessel, what is the area of supply, it comes in that. So now with those case examples, I would like to tell you what is the multivessel PCI. We need to do a complete revasculation, optimal stent expansion, minimal myocardial injury. All this hard work, we plan to do it. We do it because we want our patients to enjoy lives after PCI like this. If a patient of post-CABG in ICUs with multiple drips and they keep suffering with pain and all that, whereas the post-PCI, the patients can enjoy life. That's why we keep struggling. and do it not only give the satisfaction and comfort to the patients, but we need to do a total revasculation, give them long-term benefits. That's how now we show that PCI versus CABG, PCI numbers are increasing, CABG numbers would decrease, and with the availability of better quality equipment, better stents, these numbers would further increase, and CABG would further decrease. But the strength of surgeon would be Lima to LAD, and probably a hybrid revasculation where Lima could be given, and then stents could be offered to RC and LCX with regulating stents rather than vein, could be best for patients. But we need to organize ourselves, have a hybrid cath labs, and we're happy that Apollo started the third lab with that setup, but we have not come with packages to do what is like that. As of now, we are running separate, but if you can do something like that, patient could get the best. And we also need to work even in the acute MI setups and primary PCIs, how to combine and improve on these patients of multivessel PCI further. So if you ask patients always would love to have a less invasive PCI, but we need to see ourselves and have a heart team approach and involve everybody along with patient and do a good job to the patients. And that's how the heart team collaborative approach does good to the patients. As a broad rule, anybody who has a syntax score of less than 32, again, still could benefit by multivessel PCI. Even in patients who have more than 33 syntax score, if we can have image guidance and do the preparations well, and actually do a complete revasculation, patients could do well. That's what an Excel trial, significant number of patients were having more than that also benefited. But again, left main alone can be tackled. Left main along with, again, multivessel disease, having CTOs, that's where I think surgery has its own role to play. With this, I will close here and take you through a live in a box case and try to conserve another 10 minutes of time for discussion. Give me 1 minute to close this and open the live in a box case. So in this thing, what I would cover in the 10 minutes of time is basically take you through some of the steps of assessing the calcium with technology, with guidance of OCT, and also how we came to DC. This is take you through the case example: 64-year-old hypertensive diabetic and had unstable angina and recurrent rest angina. In the process, she also developed right hemiparesis. That's where they became uncomfortable. And she also suffered COVID in this COVID era and recovered. Then that's how the patient was referred to us from Guntur, and then advised CABG, but again, it was deferred because of neuro and CT teams because of history of TIA and COVID, and then risk benefits are explained. The best part of this patient was, the good thing is normal renal function, normal GFR, and normal LV function. The bad things for surgery, no for surgery, a recent stroke, and then the patient was frail and not very fit for surgery. Watch this angiograms carefully. This patient had a tight mid-LAD disease and a very critical OM disease. You see it's almost subtotal occlusion OM. If you see the LAD, again, LAD has a long segment calcific disease. If a patient has this tram-tack appearance of two sides, two arterial walls seen in angiogram, that is a sign of severe calcification. And if it is seen only on movement, that means it is slightly less. Even if seen even in rest, that means that is the severest possible calcium which a patient can have. You have different modalities, different classifications with imaging. I will take you through, but this is how you assess on the angiogram. If you see the right coronary artery, again, it has two levels of disease there, proximal and mid. And you have to again assess whether the osteums are involved in it or not, because always, unless disease is there extending into osteum, you tend to avoid osteum because osteum, again, could be having higher risk stenosis. Same is the case. You tend to avoid the bifurcations because, again, as I said, occlusion of the branches could lead to increased smaller myocardial infarction during the procedure. So our aim is to avoid the bigger branches if possible, if the lesions are not extending there, and also avoid osteum if possible. So we know this concept of MLD, concept of OCT. Pre-procedure, we want to assess the morphology, length and diameter. Post-procedure, medial dissection, opposition, expansion. This we covered with OCT. The talk of intracoronary imaging. Initially, our plan was to image OCT from mid to proximal. The idea is to see if we can avoid going on to the left main and the ostium of it, because unless it is important to try to avoid extending onto the left main, because procedures become complicated. And you see the LAD, LCX proximal vessels, though you have fibrous calcific plaque was there in the mid LAD. Fortunately, the proximal LADs and LCX bifurcation areas calculated on OCT were not important. So, but the mid LAD, if you see it here, the calcium was extending here, seen clearly, and the area was the tightest 1.24. So, mid LAD anyway need to be planned, tackled. This is the anatomy. Now, for the sake of time, I will go to the important phase in this live in a box, and you can watch it and have it see. Now,
this is cranial views which showed disease. So this is a mid LAD OCT being recorded, and we'll analyze the OCT pictures. And the OCT showed that probably distal place where the landing zone is all right, and the proximal hump we can get away. And the plan is now to stent that hump portion to mid LAD portion. Now we dilated with a balloon because of calcium presence, and there's one point in the LAD showed circumferential calcium. And if you see there, the 2.5 NC balloon also didn't expand. 2.25 NC didn't expand. Then we went up to took another 2.5 NC balloon and expanded with very high pressure of 20. Still unexpanded portion you can see there. Still it is not expanded. Then now it has yielded at 20 atmospheres with 2.5 NC. Because we prepared the bed well, we took a 2.538. Intima to intima, it showed 2.3, and EL into EL, it showed 2.6. So we thought 2.5 into 38 stent will place it. Check that position to end that in the proximal hump. Then that's the final position. We inflated the stent. Distally, it looks fine. Then because the long stent and 2.5, we took a 2.75 NC. Then serial dilatations are being given. Then the tightest portion where it had a block, we made it a point to cover it. That's the appearance which looks good. We wanted to study it with the OCT. The OCT picture shows L-expanded stent, but for that calcific zone. Now we wanted to make sure that osteal LAD lesion, what we left is not physiologically important. That is where we are taking the FFR wire now. We studied the RFR. RFR came negative. So we thought we could leave LAD osteum like that. Now we went into LCX. LCX RFR is studied. LCX RFR, obviously distally it came positive. Both the lesions were looking important. The LCX being wired, we dilated with the 2.25 mm balloon. You see the tight waist there, which didn't yield before. It yielded at higher pressure. That's a dissection there. We were thinking whether to use only drug-eluting balloon, but because of a dissection, then we decided to put a 2.25 stent. The proximal portion was a little troubling, but fortunately, signs we could track. The marker-to-marker advantage is again here at the osteal location. Then we inflated 2.25 stent there. There's no dissection distally. That's a 2.515 stent inflated. You see that the residual waste was there, which we inflated again with a 2.75 NC balloon. That is the appearance after the proximal. Now we are checking the RFR again. That RFR in both the sides came negative. That is the advantage of treating the proximal vessel if it becomes important. And the OM flow is maintained, though lower division shows disease, but because of a normal thing, then we left. Now we have decided to go onto the right coronary artery. So this is the right coronary artery picture now, which shows two levels of disease, mid-segment tight disease and the proximal disease. Now after finishing the left side, now we hook the right catheter with 5 French because also the spasm and artery also looks small. And 5 French JR catheter. As you see it there, the mid-segment long segment disease and proximal side stenosis. Another point I wanted to highlight this, in a team we always practice this, is when you're doing multivessel PCI, operator could get exhausted, and it's always better to have another colleague who is equally competent and senior enough. So we always change, and now we become an assistant to the main. The second operator becomes the main operator. Now we go on to right coronary artery. Hopefully, we should be able to predilate and take care with a long stent. Because stent is still underexpanded even at 20 atmospheres NC balloon. There is some residual under-expanded balloon there, but we thought we have opened with 2.25, which could go. 38 mm Zain's expedition tracked it so well, we thought lesion is open. Then we positioned it well. Just we didn't want to cover the ostium totally because ostium was free from disease. We wanted to do it from the conal branch. Next. Then we expanded 14, 18, but the residual waste at that point where we had a suspicion on the balloon was persisting. We didn't want to come out totally. We withdrew the stent balloon little, not to have distal dissection. We covered the proximal portion, which was again not stented, with a guide and tried to do little high pressure inflations here, but it didn't work. Next, then we have taken another NC balloon 3 into 10. We expanded. That went in easily, but the residual waste was persisting. That can be seen. We went on to further to take expand. Then the bigger balloon, we thought the balloon with Ironman-like thing could help. We put a more stronger Grand Slam wire. Second balloon, second wiring also didn't help because basically it was holding at that bend. We took another thinner balloon. Again, this went.
This is the OPN balloon, in which we are expanding. Then finally, at that atmosphere of pressure with the OPN, it opened. So this is the OCT appearance. For sake of time, I'm running through. Then this is the you have the lesion points assessment, proximal, mid, and distal. Your good areas which you got. This is the most important thing in the RCA. You see that OPN balloon, which can take a high pressure double layered balloon. Now it gave up. You see that waste was there before. It opened up at 40 atmospheres. That's how the calcific lesions. That's important. If you see this poor man's eye was like this is a stent whiz. The narrowing remained in the stent. We keep on expanded with a high pressure. That's how it yielded up. You need to tackle these vessels well, and then later on, we wanted to image before with OCT before expansion. It couldn't do it. Later on, we expanded and saw with the stent. And that's how you could get a reasonably good areas without dissection, and patient did well. These are the problems with calcific nodules now. Approach is you have various modalities to investigate. IVUS OCT has its own advantages and disadvantages. We discussed in this assessment. If a patient has calcium all across more than 50% thickness, being more than 5 mm and more than 5 mm length, that's where I think scores come higher. Then you need more calcium modifications with IVL type of balloons. With fibrosis type of it, then probably you can manage without even taking those. So the worst calciums are being managed with IVL. Mid-type is managed by the OPN balloons, and milder ones could be tackled with NC balloons. I think this take-home message, I need to stop here. The bed preparation is most important. In the LAD, you prepared the bed well. That's how you had immediately no problem with stent. In RCA, though we thought we prepared the bed well, but it was not sufficient. Then stent after stent under expansion, luckily with the availability of high pressure OPN balloons, we could tackle it. So availability of all the required hardware is mandatory when we're dealing with complex PCIs. I think with this, I will stop. You should excuse me for not taking part in the chat today. And I assure you that I will again take care of all these discussions in my next module, which will be communicated to you. And I have committed for some international program. Please excuse me, because initially we thought we would do this tomorrow because of confusion with micro, but my apologies. We will again have discussion definitely again when we have the next module. Hope you like this presentation and for things today. I think Jignesh, I will stop here and go on to, I have to leave. Thank you for all patient reading.
Thank you, sir. Thank you very much, sir. And
not
also
able to hear
thanks
you,
for
Jignesh.
all.
Unmute
Sir?
yourself. Thank you.
Oh, sorry. Thank you, doctors. Thanks for this wonderful evening, and also